There are two forms of COPD. Thank you. There used to be three. The third one used to be asthma. They removed asthma out of COPD and placed asthma under allergic reactions or allergic conditions. So what is COPD? Number one cause is smoking. There are, of course, other causes. We'll discuss a couple more later, but the most common cause is smoking. Doesn't matter if it's first-hand, second, or third-hand smoking. Exposure to the substances, the chemicals in the tobacco causes the reactions that cause the changes in the person's upper and lower airways. The number one basis for diagnosing you with COPD is FEV1. We measure your FEV1. What is that? This is measured using a spirometer. Now, when you say spirometer, we're not referring to that little disposable device that you go give your post-op or bedbound patients, the one that they breathe in, inhale into. We're not referring to that. A spirometer is a larger machine. You can only see spirometers in a doctor's office. We don't have it in the hospital either, unless there's a clinic in the hospital. Then yeah, these are only found in clinics. Because in the first place, we do not measure FEV1 if you're hospitalized. It's useless, okay, because you're already sick. So we need to measure FEV1 when you are feeling good, right? You're not acutely ill. Does that make sense? Okay, so that's why will we see spirometers in the hospital? Only in a clinic, okay, either a doctor's clinic or a clinic at the hospital. So FEV1 means you're going to blow into a hose connected to the spirometer, and it will measure the forced expiratory volume in 1 second. So you'll perform it several times. You'll rest, of course, in between, and we will record the highest reading. We'll get to the results later under the diagnostic section. The first type of COPD is emphysema. Oh no, chronic bronchitis is mentioned first, so let's do that first. Up here, I'll mention this now since it's mentioned here. Proteinases and anti-proteinases. What are these substances? Protease or proteinase is a substance, an enzyme that will break down debris that enters your airway, meaning these are enzymes found in your upper and lower airways produced by another protein which is called antitrypsin 1, alpha antitrypsin 1. And with alpha antitrypsin 1, then you can make protease, right? So protease, again, is an enzyme that will dissolve or digest debris from your airways. Are we breathing in sterile air? So is our respiratory tract sterile? Yes or no? Are your lungs sterile? Yes or no?
Yes.
Does that sound sterile to you? No. So our respiratory tract is not sterile. Okay. So therefore, how do we keep it clean? We need the proteinase. Okay. So this will, whatever you inhale. Okay. So you inhale poop, like say bird poop dries up or dog poop dries up. You inhale it. Don't worry. You have the proteinase. Okay. It will clean whatever is stuck there. So, and we also have mucus, right? So anything dry particles will stick to the mucus, and then that's, the mucus, your cilia will propel it, and then you can spit the mucus, or your proteinase will destroy them, right? Okay. Some patients have a deficiency, a genetic deficiency of alpha-1 antitrypsin. That's why Although half of your patients with COPD are smokers, the other percentage are not necessarily smokers. Okay, so meaning they've never been exposed to smoke. They live in a clean household, non-smoking household. They're pampered. They've never been in riding in public transportation. No, they ride your own cars, smoke-free vehicles. Okay, and at work, no, they're never exposed to smokers, but yet they have COPD. So this is the small portion, about maybe 1 to 10% of the COPD patients have a genetic deficiency of alpha-1 antitrypsin. So they do not have proteinase. They don't have protease. So therefore, can they clean their airway? As a result, they develop COPD. Okay, we'll get to the changes after shortly. So let's start with chronic bronchitis. As opposed to acute, most of us will have acute bronchitis every now and then, especially in the fall. We get the flu. You get diagnosed with the flu, but you definitely have acute bronchitis also because of the flu. Have you ever had a really bad cough? You've had a cough for 3 days or longer. So that's acute bronchitis. Okay. That heals. No problem with that. That's not COPD. Chronic bronchitis is COPD. Okay. So what happens here? So let's use a smoker as an example. So when you smoke, every time you puff that smoke, what substances are in your airway? Yeah, besides nicotine, there's also some whatever chemicals is left in there, right? Like tar. Yeah, so you have so many chemicals in that tobacco. So what will happen to your mucus production? It will increase naturally as a reaction to you're constantly exposing your airway and your lungs to irritants, right? So therefore, what will happen to the mucus producing cells? The size of them, they will enlarge. So therefore, when they enlarge, what will happen to their production? Increase as well. When you sleep, can you smoke while you sleep? Okay. So over time, you smoke for months, years, decades now. So you have larger than normal mucus producing cells, correct? And then you stop smoking when you sleep. So what happens to their activity? Do they necessarily stop? They are accustomed to producing the mucus. Okay, so therefore, what will happen to the integrity of your airway? Because of the enlarged and sticky and thick mucus. Okay, overproduction of really thick and large amount of mucus will obstruct your airway. And then what happened to is there going to be inflammation? Okay, so inflammation, chronic or acute inflammation? Chronic, because you're a chronic smoker. And what happens to the cilia eventually? What's the purpose of your cilia? Those hair-like productions? To propel mucus, right? Upwards from your lower airways, upward toward your... So if they have to carry all of this really thick, heavy amounts of mucus, what will happen to them over time? They get tired, they get weak, right? Or they get destroyed eventually. So what happens to your mucus clearing ability? So that's what chronic bronchitis is. Any question on chronic bronchitis?
Yes,
Yes.
the mucus cells or glands, when they get larger, do they always stay like that? But
Yeah.
if the person stops smoking,
Yeah,
I've heard-
eventually,
I've
yes.
heard that if let's say a person stops smoking a couple months or a
Mhm.
year or 5 years, that the improvement of your lung health can slightly
Yes,
improve.
yes, there's always a difference. So this is very good point you're bringing up. So therefore, when you get responses from your patients, let's say you're doing smoking cessation education, right? So you give them pamphlets, ways to quit smoking, and then every time you attempt that, they'll say, "Oh, thank you very much, but I like to smoke." Okay, so or some comments like, "Oh, it's too late for me. I'm 79. It's too late for me to stop." Is that really true? No, it's never too late to stop, right? So yes, there will be an improvement. How much? Well, it depends. How long did they smoke? Because we can't undo decades of damage either, right? Let's be realistic. They smoke for 50 years. I mean, don't expect teenage, lungs after they quit. So that's long story short. If you want the details, read the paragraph. So this is chronic bronchitis. So this is now what your airways look like. So because of the chronic inflammation, look at the thickness of the smooth muscle now. So the smooth muscle is supposed to be this thin. Because of the inflammation, when we say inflammation, what happens to the capillaries? Do they dilate or constrict? Inflammation. Let's say you hit your finger on the door. Will it dilate or constrict? Dilation, because it's inflamed, right? So chronic inflammation leads to dilation of the blood vessels. So therefore, as they dilate, they thicken the diameter of the wall, the muscle, and narrowing your opening. That's all the opening you have left. All right, so that's with chronic bronchitis. So let's move on to emphysema, because that's just one type.
Does the same thing happen in acute?
No, because in acute, there will be some swelling, but not to that extent. Plus, it's, short term. Meaning, what I'm trying to say is this did not thicken overnight. This is years in the making, all right? Doesn't happen overnight. Emphysema. This one is now involving the lower airway down to your lungs now. So chronic bronchitis affects the large airways, okay? The trachea, main stem bronchus, left and right main stem bronchi. Emphysema, this is now a gas exchange problem because this will affect the over-distended alveoli. Now, why did the alveoli overextend? So same pathophysiology. So you have smoking for years, for decades. So what will happen to the protease again? Because you have chronic smoking. So what happens to the number and activity of your protease also? Because the production will also increase, correct? So I forgot to finish this thought earlier, but it'll be the same though. So what will the protease do when they run out of smoke particles to destroy? Because you stop smoking when you sleep. You're not smoking anymore. So, well, the protease is there. What are they going to say? Well, we're here. We have to do something. We have to destroy something, but there's nothing, no cigarette to destroy. So what will they destroy? Anything they can find. So they will destroy your airways now. The alveoli will be destroyed because they're there. Okay, they have one job, which is what? Destroy something. Okay, go here. Your body releases here, go destroy something. Okay, they got nothing else to destroy. The guy stopped smoking, so we'll destroy this thing, right? So now that what happens, this is what your alveoli will look like. On the left is the normal, on the left are the normal appearing alveoli. Look at what happens to the destroyed, damaged walls. So they're supposed to be individual grapes like this, each one wrapped with a capillary network of blood vessels. When their walls are now destroyed, they become one lumpy mess. Okay, so over-distended, flabby, inelastic mess. So what's the purpose of them being individual? This allows the airways to contract and relax, right? By so doing, when you inhale and exhale, what happens to the alveoli? Okay, they expand and then recoil, push out CO2, correct? That's what they do. Day in, day out, breath after breath, 16 to 20 times every day. Here, can they do that? When they look like this. So therefore, is it easy to get air in? Is it easy to get air out? Both will be very difficult because they don't recoil anymore. They're one flabby mess. You understand? Okay. Most people though have both emphysema and chronic bronchitis. If you're a smoker, you will have both. Some lucky people will have one or the other, but most COPD patients, the one you frequently see in the hospital, and they'll be the same people, okay? Because why do they go to your hospital? That means they live near that hospital, right? So therefore, are they going to be frequent customers? Yes, you'll get to know them, their families, their business, okay? By business, like who's dating who, all right? Hey, did you know? Oh, I had no idea, okay? So you'll get into those things already with these people. Hey, they become your friends. Although, is that proper patient relationship? No, but it happens though. Okay, because again, you see them every fall. Sometimes, when they overindulge, you see them also in the summer or let's say spring because of the pollen. So they react, they get exacerbation, but frequently you see them every year, like the start of fall, because they'll get pneumonia. Okay, these patients come in for exacerbation, pneumonia, and then moreover, if you go up here, they also develop heart failure. What was it again? What we call heart failure, right side heart failure caused by respiratory problem or pulmonary hypertension, cor pulmonale right here. This is basically right side heart failure. How does that happen? How does cor pulmonale result from a chronic pulmonary condition? So let's go back here. Let's look at just the diagram, okay, the illustration. If your lungs look like this, remember there are pulmonary arteries supplying each lung, correct? So what happens to the blood pressure in the pulmonary arteries if they look like this? Increases. So therefore the afterload is high, correct? High afterload. Which side of the heart pumps blood to the pulmonary arteries? The right side, correct? So therefore, what happens to the workload of the right ventricle against because that's pretty much pulmonary hypertension, correct? So if there's increased afterload in the pulmonary arteries, then we call that pulmonary hypertension. So what happens to the right side eventually over decades, years? Same thing. Heart failure symptoms appear. Any questions? Okay. So do COPD patients have heart failure? Yes, it's guaranteed. It just comes with the territory. Develop COPD, that means you have what type of heart failure? Right side. As a compensatory response to, because what happens to the patient's oxygen level here from day to day? It's going to decrease, correct? Because let's say you have both emphysema and chronic bronchitis. So what happens to your air intake? Okay, very hard, right? Very difficult. So oxygen levels drop. And to compensate, what will your body do? If they can't get enough oxygen, what will your bone marrow do? It's going to increase red blood cell production. So the patients will have polycythemia. Have you heard the term pink puffers? Have you ever seen a COPD patient?
Yeah.
What do they look like? They look very Republican. They're very red. Okay? They look flushed.
Yeah.
No, it's true. Yeah, if you look at these patients, they look very flushed. Like they're, like they're overexerting all the time. They look red. No, not that bad though.
That's how we look.
They appear flushed all the time. That's because of the polycythemia. They have increased red blood cells to compensate for it's a effort to increase oxygen carrying capacity because the body's just desperate, We've been low oxygen all the time. Let's increase red blood cell production. Maybe that will improve oxygenation. Right? So it's a compensatory reaction. Risk factors again, number one is cigarette smoking. More than half of your patients are smokers. Doesn't matter again, first, second, third hand smoking, that's the same chemicals. Okay, so chart 20-1, we have their tobacco. Increased age also, especially if that old person also has asthma. The asthma can increase the risk of COPD as well. Or the kind of work you do, or let's say where you live also, if you're exposed to other pollutants besides smoking. And I already mentioned at the start earlier, so a genetic deficiency of alpha-1 antitrypsin. All right, let's go now to diagnostic. Or I think manifestation. Okay, signs and symptoms first. We must be able to distinguish between acute and chronic manifestations of COPD. Is this also the same in heart failure? Yes, in heart failure, we had acute and chronic symptoms, right? So which ones do we worry about? The acute ones. Okay. So these patients, of course, are not normal anymore. They will have increased respiratory rate. They will have increased sputum production. Of course, the blood count will be higher. The shape of the thorax also changes, right? So we have to distinguish acute versus chronic because you have to be able to teach the patient when do they call their doctor or when do they call 911 or go to see their provider. Unfortunately, there's no table for that. So do you appreciate tables and charts now? It's easy to organize information there, right? Rather than you have to find it yourself, which is what's going to happen here. You're going to have to find them in the paragraphs. Let's start with the sputum production. What do you think would be a normal color and consistency of the sputum? Which means, you know, just like you and me, what color and consistency is okay? Clear or white, right? Okay. Should it be thick? Oh no, just you know, yeah, little thick, yeah, mucus thick, but not really like, yeah, not glue thick, okay, or not what do you call that? Cornstarch. Know what cornstarch is? Now, when you put water in cornstarch, it's really thick, right? It's like glue. What color should it be when we worry? Anything colorful. Anything other than clear or white. So when it's yellow, green, brown, orange, tan. Okay, so is that ever good? No. So that's reportable. Let's do the dyspnea. Are they dyspneic? Yes.
Yes, extremely.
Yeah, so if it's severe dyspnea, let's say, can you survive on if your respiratory rate, RR is 22 per minute?
Yeah.
Yes,
That's
I can
normal.
handle that. What about 28? That requires a lot of energy, correct? So let's say 28, so divide by 4, so that means I have to breathe 7 times in 15 seconds. Let's try that. No, that's too fast. That's already like 38 or 40.
Already feel lightheaded.
Okay. So just 7. I don't have a clock. Okay, 15 seconds.
I feel like you're breathing up this one like a cardio.
Yeah, but imagine breathing like that for 8, 12, 24 hours. No, you'll run out of energy, correct? All right, so is that reportable? Yes. What about the lung sounds? Will their lung sounds be clear? Will there be some wheezing? Okay, some wheezing is treatable, meaning they can grab their inhalers. We'll get to the treatments later. That can be, but what if the wheezing doesn't disappear? Or the wheezing is now very audible with with accompanied with an increase in respiratory rate, 28 or higher. Yes, definitely they report that or they call 911 for that. The shape of the chest, the barrel chest, is this acute or chronic? Because this did not develop overnight. This took years to form. Okay. So why did it change shape?
Again, bigger, they're using the accessory muscle.
Not only that, remember the shape of the alveoli earlier? So they were thick and flabby, correct? So do they ever completely empty? No, there's so much residual air there, because if they can't get rid of the old air, can they get new air in? No. So that's what contributes to CO2 retention. Meaning, think of it this way. Who snorkels here? Who has ever snorkeled? Okay. When you snorkel, how long can you snorkel before you need to like stop and rest?
Not long.
Pressure.
No snorkeling.
Never mind.
Okay. So everybody knows what a snorkel is.
Yeah.
So imagine a really long snorkel, okay? So the first time you put the snorkel on, let's say it's really long. Snorkels are usually a foot long. Let's say you have a 2 feet long snorkel. And then the first time you breathe, what did you breathe in? Air, room air, correct? When you exhaled, what's in that snorkel? There's some CO2 there. So the next breath I take, what did I breathe? Some of the CO2 and then some new air, correct? So multiply that over, let's say, 1,000 breaths. What do I keep rebreathing? Same idea. So those flabby alveoli that they have, you know, the walls are already damaged. Instead of individual grapes, they became one big lumpy mess. That's all filled with CO2. So when you inhale air, can they get rid of the old one? No, it's stuck there. Okay, so very hard because they can't exhale it because the alveoli are damaged. They don't have the recoil ability anymore. So there's so much, we call that air trapping, you know, so much, pretty much we call it dead space. Okay, because that's really old air. There's no way you can get rid of it. Yes. Not every day though, but yes. Plus of course we have compensation. So the ABG may not always show acidosis, but yes, they're CO2 retainers. So yes, in to a certain extent, they are acidotic. Okay, so this is the barrel chest. Again, this is a normal adaptation to the changes in the thoracic cavity. No, instead of oblong, now it's like a perfect circle. It's now 1-to-1. What happens to the, look at the surface area for the heart. On the left, the heart there is well expanded, correct? Now, because you turn the shape into a circle, so the surface area for your lungs are smaller, and then the heart also is very compressed as a result. So what happens to cardiac output here and cardiac workload? Yeah. And they typically assume this position. We call this the tripod position. This is a relatively comfortable position for the patients to have. So they'll be using accessory muscles. They'll have this posture, okay? And then when they walk, they're already like this because of the accessory muscle use. You may or may not see retractions during exacerbations again. So what are retractions again? Yeah, so when your intercostal muscles, yeah, they collapse. Okay, yeah, they fall in. When you do that, when you see retractions, so call your respiratory therapist. Okay, they need intervention. Okay, because that means what are they doing? They're gasping. Okay, overexerting. Okay, so when you see retractions, do you leave them alone?
No.
Okay, do you say, oh, serves you right? Kept smoking. Who told you to smoke? Will you say that? Okay, of course you help, okay? Give them a a nebulizer, or maybe we need to put the patient on a BiPAP, CPAP. All right. So diagnostic findings I already mentioned earlier. We're going to use spirometry. Where do you see spirometry again? In a clinic, okay? Doctor's office or a hospital clinic. This is to diagnose the severity. So remember we had 4 New York Heart Association classifications of heart failure, right? Class 1, 2, 3, and 4. So for COPD, we have gold classification. So we have about the same equivalent in heart failure, class 1, 2, 3, and 4. Class 1 meaning they have COPD, but they do okay. Okay, they can keep their job, as a nurse or whatever. They can continue. Just going to the gold. There's a table here. Okay, right here. Table 20-1. So this is the corresponding FEV1 for each grade. So grade 1, 2, 3, 4. Look at grade 4. FEV1 is less than 70%. Oh, no, sorry, less than 30%. What can you do if it's already, meaning when you blow into this, that measures basically what? The strength of your lungs, right? How much can it do? So if it's only doing less than 30%, what can it do? Can it provide the necessary oxygen you need for making ATP to, have energy to do anything? Not with 30%. Right? So that's the severity. At least you have an idea of when you read the patient's chart, what grade is the COPD? So when you see grade 3, grade 4, what's the picture of this patient? Bedbound, right? Bedbound, gasping for air, 24-hour, 24/7 oxygen. Okay. So if you smoke, you still want to smoke? All right, so just saying, okay? So think of it. So I have many smokers in my family. My dad's smoked since he was 7 years old. 7. He was from China. Okay, I don't know what his life was, but all I knew was he was a stowaway. So he escaped communist China, went to the Philippines, and lived on the streets. Because he didn't have, well, he had cousins, who were also like him, like stowaways like him, but pretty much no parents. All right, so that's he learned, smoke on the streets, and this was the war, during the war era. So as I said, what will happen to these patients every year? Okay, so we get the flu, okay, pneumonia, they get whatever, COVID, okay, high risk for COVID, for RSV. So they'll get sick and get admitted. Of course, that will lead to exacerbation, or just like heart failure, they'll have acute decompensated heart failure. So the equivalent here will be acute exacerbation of COPD. So we need to increase their treatment. We get to the treatment shortly. We already mentioned about polycythemia and heart failure that will result. Here's the management. Management is under asthma, which is above or on the previous page. So let's go to, because asthma and COPD treatment is the same. Now I'm looking for asthma.
Because I have a question.
6:32.
Okay, thank you. Okay, so let's go under management. So 634 or whatever page it is on yours. So drug therapy is, we are under asthma here because again, the treatment is identical. There are tables here. First group are quick relief medications, meaning they bring this everywhere. Everywhere they go, they carry these inhalers. So they are SABAs, short-acting beta-2 adrenergic agonists. Just a reminder, when we say beta-2 adrenergic agonists, what is the effect of these drugs? So when we say adrenergic,
They call it, I mean, no, of the epinephrine.
okay, so same as epinephrine or epinephrine. So they cause vasoconstriction. When we do vasoconstriction, what happens to the bronchus? They dilate. Okay. You see the picture there? Because remember I said, how did the chronic bronchitis airway get so thick? Because the vessels were dilated, correct? That's why the wall thickened. So if you do the opposite, you give them a drug which resembles epinephrine, so it will cause vasoconstriction. So therefore, the diameter wall will thin and then enlarge the opening. Make sense? Okay. Then we got anticholinergics. The problem with beta-2 adrenergic agonists is they increase the heart rate. That's the number one side effect, is increases heart rate. Remember, these patients have heart failure, correct? So if they have heart failure, could they develop dysrhythmias?
Yeah.
Could they also develop like atrial fibrillation? Okay, so if there's a heart condition, can we give them epinephrine, which increases heart rate? No. So in that case, we will give anticholinergics like ipratropium, which inhibit muscarinic, meaning it still causes vasoconstriction without the increase in heart rate. Okay? So that's an option, but both are SABAs. Okay, so they quickly dilate the bronchioles, improving the symptoms. Here's your table, complete table for the SABAs. So most common drugs are albuterol, levalbuterol, and for ipratropium. And then we have steroids. Steroids, there is no such thing as a fast-acting steroids. Okay. So will this be the first thing you'll grab? No, always grab your albuterol, levalbuterol first, then steroids next, because there are no fast-acting steroids. Okay, so for long-term, this is now your LABAs, table 20-6. These are for regular maintenance use. They use these, they must understand that they need to use these whether or not they have symptoms, okay? So most patients are non-compliant with these, especially if they feel good, they don't like to use this, my wife included. I also have 2 kids with asthma like her. They follow mama also, okay? They also do not comply with their long-term treatment. So as a result, do they get exacerbations? Yes. Okay. And you should know this already, right? That whenever you give steroids, what will be the side effect?
Infection.
Infection. Okay, so if it's an inhaler, what should you tell them?
Rinse their mouth.
Okay, they should be cleaning their mouth. Brush your teeth, or at least rinse their mouth. Gargle, swish, and spit after using any steroids. So these are the names of the steroids. What do they all end in? Zone, right? So we got beclomethasone, fluticasone, mometasone. All right. Now there are non-inhaler options here. Non-steroid. Yeah, correct. Non-inhaler. We also have tablets prescribed. For the steroids, we typically place them on IV steroids when they come in for an exacerbation, because they've been using the steroids, inhaled steroids at home. So that's not going to work anymore. So when they come in for an exacerbation, we give them IV steroids now. for typically 3 days, depending on how bad. So 3 days, and then we taper off after that. We switch back to either PO or back to their inhaled steroids. Some of these drugs are in combination, and they'll put multiple drugs, 2 or 3 drugs in one inhaler. Okay, so that's a common practice for drug companies. That way you only take one medicine, okay, you inhale one inhaler, and there are 3 drugs in there. All right, so very efficient. Of course, there's 3 drugs, so 3 different sets of side effects. Theophylline is a very old bronchodilator. So this was in the, one of the earliest long-acting bronchodilators. It's still in the market, but very few prescriptions. You'll see them once in a while. This is the most common combination. You heard of Advair, a purple disc? Okay, so this is the most popular combination. You have fluticasone, the steroid, and the salmeterol, a long-acting bronchodilator. Very effective, very popular among asthma and COPD patients. This is the tablet form, leukotriene antagonist. This is for children, 5 milligrams, adults, 10 milligrams. So you take it once a day, usually in the evening, right? Once a day. And this has less side effects compared to the other treatments, because this one is specific for the leukotriene only. So what is leukotriene? It's one of the inflammatory mediators, like histamine. Yeah, those, but this one is specific. It only targets this cytokine, so it doesn't affect all the others, because you need the rest of your immune system, correct, to fight infection. So this one doesn't suppress only leukotriene. And leukotriene has been known to be responsible for the symptoms in asthma and COPD. Meaning they cause the symptoms, the inflammation, the bronchoconstriction, and the shortness of breath. The rest of these are injections and IV infusions, immunomodulators. They're very expensive. So these we reserve for really serious cases. Let's go now to the reason for admission. Because patients take these medications for a long time, correct? Forever, pretty much. So what would be key to successful treatment? Just like with TB, we said TB, what's the key to successful eradication of tuberculosis? Medication compliance. So let's say they take the medications. Are they taking it correctly? That's the problem. So most people, myself included, we take it for granted. We assume, anybody can use an inhaler. Actually, no. Okay, not all people are very good or are using them correctly. Now, let's go back to, we're done here with the asthma part. Let's go back to COPD now, because we're only in the asthma section for the drugs. So let's return to COPD. We were at
603.
yes, 608. Yeah. Okay. Now, the best way to learn it is besides the paragraph is to watch a video. So I recommend 3 videos.
So you gotta just
Yeah, just go to YouTube. And then watch the video side by side with the steps. So the 3 videos I saw that are following the proper steps are, just type in metered dose inhalers or MDI. Here, the hit you'll see is metered dose inhaler demonstration right there. Then look for this chick. Okay. Yeah, watch this chick. So there'll be 3, this chick, and I'll show you the other 2 later.
wait.
So this is for the MDI, okay?
Which one again? The channel is
Meter dose inhaler.
Use inhalers for.
Yeah, how to use meter dose inhalers correctly.
The white lady. Hold on.
Remove the cap from the inhaler.
Yeah.
Shake the inhaler.
Shake the inhaler well for 5 seconds.
By the way,
Hold the inhaler.
meter dose inhalers are wet. Okay, they're in a canister, and this is the handheld device. So you put the canister into upside down into the device, and when you press, it will spray. Not just like your house sprays. No, you press right to spray, kind of like that. Actually, exactly like that. So it will spray wet medication. So therefore, what do you do when you spray it? It's wet, so you will inhale. Okay, so when you spray, you will inhale. So that's where the problem is. So not all people do it correctly, because it's I mean, face it, if it's a small child, can they do it correctly? Or a really old timer? No, right? So it's difficult for some people. So if the patient's able, this is what you recommend.
Firmly, by placing your index finger on top of the canister and thumb on the bottom of the mouthpiece. Sit up straight or stand up. Tilt your head back slightly. Exhale away from the inhaler. Put the inhaler in your mouth. Press the inhaler and start breathing in at the same time. Take a slow and deep breath. Hold your breath for 10 seconds. Exhale slowly through your mouth or nose.
It should really be up to 10 seconds, okay? So let's say this patient's obese, can they hold it for 10 seconds? So up to 10 seconds, if they can.
Repeat 2 to 8 steps after 30 seconds if another dose is required.
Meaning, if you, let's say the prescription is 2 puffs once or twice a day, do you do it like this? Because most people do it like this.
Yeah.
No,
Yeah.
that's not the correct. Yeah, but you see people doing that, right? So they should wait how long?
30 seconds.
What happens if you do it consecutively?
It's not.
You're
open.
not getting it. Okay, so you should rest for 30 seconds. Okay, allow that first drug to disperse first, and then after you've rested, and then you, plus let's face it, are you really inhaling deep if you do it consecutively?
No.
No, the second breath is shallow. So where did the medication go? In your teeth. Is that where it's supposed to be? It's supposed to be in your lungs, as deep in your lungs as possible. Are we clear? All right. So let's watch the second, which is, let's change this now to with a spacer, because this is the recommended technique. You should use it with a spacer. Let's use this one, this model now. You see this chick? Okay. You see the model? Oh, wait a minute. It's playing already.
Was it- what that was? Use it.
So how to use MDI with spacer?
It's
All right, you ready? Okay, so let's watch. So it's the same few steps. The only difference is we're going to attach the inhaler mouthpiece
remove the
to
cap from the inhaler.
spacer. First few steps the same.
Remove the cap from the spacer. Shake the inhaler well for 5 seconds. Insert the inhaler into the open end of the chamber. Ensure that the inhaler fits properly.
Okay. Keep in mind though, by the way, anything you put into your mouth, what does it have now? Because you put it into your mouth. It's saliva, right? With bacteria. So what do you do with after that with the device? Okay, wash it with under running water. Okay, and even wash it with soap and water. It's fine. You're not gonna damage the drug because the drug is inside the canister. Okay, it's wet. It's already wet. So plus the water doesn't really enter the canister, does it? No. Are we clear? Okay, so the purpose of this air chamber, air chamber is a brand. So the purpose of the spacer device is to allow the medication to circulate into the chamber, allowing the patient sufficient time to take their time, their nice and easy time to inhale. So they just go puff and then as slow and deep as they can, and they get all of the medication. Okay, so no hurry, no rush.
Sit up straight or stand up. Tilt your head back slightly. Before starting to inhale, breathe out completely away from the spacer. Place the mouthpiece between your teeth and seal your lips tightly around it. Press the inhaler once, and then breathe in steadily and deeply.
So that's what I mean by
Hold your breath for 10 seconds.
there's no rush. Okay, so they can take their sweet time inhaling, and they get the maximum dose possible. Right? So spacer is the recommended technique. Spacers, by the way, come in different forms. Spacers can also look like well, there's a picture on your book. It's a different spacer there. It's not here. Probably in a different chapter. But a spacer can be like a mask. Okay, so instead of it putting in your mouth, the end that goes to your mouth will be like this. Okay, it will cover. Yeah, it'll be. Sorry. 646. 616. Yeah, maybe. Yeah, that one. It can look like this. Okay, it can be like a mask instead of a mouthpiece. All right. Okay, last one would be a powder, because we also have medications in a powder, like Advair. Advair is of course, a powder won't have a spacer. But just type in dry powder inhaler. No, this chick. This one. Same company, different model.
Properly in both the hand.
So this is Advair demonstration.
Check the dose counter to see the number of doses remaining. Hold the inhaler properly in both the hands. Open the inhaler by using the thumb grip slide. You'll hear a click. Hold the inhaler horizontally. For loading the dose, slide the lever from left to right. You'll hear a click.
Okay. So what are you looking at? The disc pretty much has, so it's like a hamburger, right? So the medications, about 30 to 60 doses, are on a disc around the device. So what it does is there were 2 clicks, right? First click was to open the mouthpiece. The second click was to open a dose that we're gonna puncture. There's a needle inside that will puncture one of the capsules that are inside. So once the capsule is open, of course, this is not a spray. You'll have to inhale the contents of that capsule, which is already open. So they tell you to hold it horizontal, because what happens if you tip it down? The powder will go onto your shoes. Okay, so you hold it flat like this horizontally. After you click, that opens the dose, right? So the capsule is now open. So you keep it horizontal, and then you suck that into your lungs.
Exhale away from the inhaler.
So very important, especially this one, because this is powder. If you inhale into
Place the mouthpiece in your mouth.
mouthpiece,
Take a quick and deep breath.
what will happen to the powder if you inhale into it? If she exhaled in front of it, what will happen to the powder? Yeah, it will blow out. Plus, it will also moisture goes in, and then now the powder is now clumpy. Okay. Remember, this is dry powder inside, so you can't get it wet.
Hold your breath for 10 seconds. Exhale slowly through your mouth or nose.
The powder is very fine. You won't notice it. Finer than cocaine. So when you snort this, you won't see anything.
If you are using Flovent Discus and have been prescribed to take another dose, then repeat the steps from 3 to 6 after 30 seconds.
How many seconds always in between doses? At least 30. Okay, you can wait even longer. 1 minute is better, especially if you're short of breath. Okay, so you rest, and then that way when you breathe, it's really a good strong breath, and you take as much of the medication as deep into your lungs as possible. Any question about the techniques? Okay. Do we wash this under running water? Why not? It's powder, so it's gonna get your powdered medications wet, so you can't wash this. So what do? I have spit on the mouthpiece. Okay, you can clean it with any clean cloth, but no running water, right? Let's see if we're done. Of course, again, we promote smoking cessation, correct? Okay, let's go to oxygen therapy because these patients need oxygen. Go back to 608. Go under general principles of oxygen therapy. Okay, what did you learn in fundamentals about COPD and oxygen?
Let's review together, sir.
Or even last semester? What did you learn?
Huh?
Okay,
For COPD patients. we
How
can't go
much-
past 2 liters because it's toxic.
okay, can you repeat that? They can't hear you, 'cause they were busy.
For COPD patients, we can't go past 2 liters because of they have a problem taking in air. If we give them too much, it's gonna become toxic.
Okay, the rationale to clean it up, it's really because you and me, what drives us to breathe? Let's say we don't have COPD. Why do we keep breathing? Have you ever thought about that? Why don't we stop breathing?
Because of that.
Because when you stop breathing, let's say I decide, okay, I'm gonna stop, I won't breathe. What will happen to my CO2 levels?
It increases.
It's gonna rise, right? So what's therefore driving me to breathe? When I hold my breath, why isn't it possible to commit suicide by holding my breath?
Because it's
Okay, because right, because my brain will automatically override my will, correct? Meaning, what was the stimulus? High CO2. So when my CO2 levels rise because I stop breathing, it will drive me to breathe. Okay, whether I like it or not, I will inhale. Okay, I'll be forced to take a deep inspiration. In COPD patients, what is their day-to-day CO2 levels like? It's already high. So therefore, will that original stimulus still be around for COPD patients? No more. Their body got so used to high CO2 levels that they don't respond to that anymore. So they have to respond to something else. This time, they will respond to low oxygen levels. Again, normal people, the drive to breathe is what? High CO2 levels. In COPD patients, chronic bronchitis emphysema, what is their drive to breathe? Low oxygen levels. Okay. In theory, I repeat, in theory, we do not give COPD patients too much oxygen. You can give them maybe 4 liters. Okay. Theoretically. Okay. Because what will that do if we give them too much oxygen? Because now if their oxygen levels are high, what will happen to their drive to breathe? You take it away. So therefore, if the oxygen levels are already high, will they ever breathe again? No, brain will say, why do I need to breathe? Oxygen levels are already high. You get it?
Yeah.
Again, that is in theory, okay? In theory, that is what will guide us. However, you'll see here in your textbook, if the patient is, let's say, look at this paragraph. So when the patient is admitted in the hospital, which is when you see COPD patients, right? Because are they in the hospital if they're okay? No. So you admit them because what are they here for? An exacerbation. So they're having shortness of breath. So let's say they got the flu, they got pneumonia, they're sick. So they have an acute flare-up or exacerbation. This time, will they need oxygen? Yes, they do. Do you limit them to 2 to 4 liters? If the oxygen saturation is less than, let's say, less than 90 or less than 88, they're at 86, 87. Do you stand there and say, no, sorry, sir, you're COPD. I can't give you too much oxygen, more than 4 liters. Okay, I'm sorry. So what's gonna happen? So you deprive them of oxygen?
No.
So what does this say? Look at the, if you read the paragraph silently, okay?
Which
This one from the silently like this in your head. Signaling the need for supplemental oxygen may depend on how suddenly this need develops.
Can't read.
Then let's read the last statement out loud. The need for oxygen is assessed by ABG analysis, pulse oximetry, and clinical evaluation. So what is the basis again? The need for oxygen
ABG.
and oxygen saturation. So the acceptable oxygen saturation is at least 90 or better. So if the patient is saturating 88, 86 on your 4 liters of oxygen, do you give oxygen? So screw them.
Call and check.
Okay, this is what it means. See, the need for oxygen is assessed by ABG, pulse ox, and clinical evaluation. So if the pulse ox is less than 88 or less than 90, 88, 86, 85, do you give more than 4 liters of oxygen? Please give them more oxygen. Are we clear? Because do they need it? Yes, they need it. Okay? So don't worry, we're not going to leave them on 6, 8, or 10 liters forever. We're just going to give it because they need it. So if the respiratory rate is now back to normal, their oxygen saturation is at least more than 90%, do you titrate down? Yes, please do. Okay, because remember, oxygen is a drug. Do you keep them on those drugs if they don't need it anymore? No, so you constantly reassess. Are we clear? All right, yes, ma'am.
Sir, you know how oxygen is toxic as well, right? So when do you get consent from the doctor? Like when as a nurse can, I know there's a point where you can go into,
Anytime. You always ask for an order. You don't give oxygen. No, don't take it literally, okay? Don't mean, let's say my doctor's at the barber shop. Okay, he's being shaved. Can he answer his phone? Meanwhile, your patient's gasping for air. Can you say, oh, the haircut and the shave should be done in about 15 minutes, okay? Hold on for me. Okay? So what will happen? Give it, get the order as soon as you can. Okay, in reality. Okay. But don't worry, the NCLEX won't put you in that scenario. Okay. But if oxygen is on the choice, it's as good as any other choice. Okay, don't stop the looking for orders or anything. Okay. If it's on the list of choices, what orders will you carry out? Assume there's an order. All right.
So regarding getting an order from the doctor, I mean, like in school, we always taught like you get an order first, but if it's an emergency situation, is it like, you had said in, I think, the last class, it's understood that if it's an emergency situation, that it kind of overrides the get the order first before you do?
Yeah.
Get the order.
It applies here as well.
Got it.
Okay, so please give them oxygen.
Regular nasal cannula or mask?
Yep.
You didn't talk about,
Which
you
one?
have an exam next week, you didn't even say nothing.
Because I already put the blueprint on Canvas. So I already told you ahead of time
They want.
what's gonna be on the exam.
Regular
Why do I have to repeat it? I told you, all the exams doesn't change. It's always 50 for unit exams, 100 for the final, 10 for quizzes.
Sir, regular nasal cannula?
Well, depends on how much are you giving.